So I'll be presenting some work that we have done as part of the PETAL research program on using electronic case records to better understand challenging behavior in people with intellectual disability. And again, with a particular focus on aggressive challenging behavior, but also on mental health. And I would like to acknowledge that some of the work has been published. So the covering work that has recently been published in the European Psychiatry, and there's another piece of work that's in submission at the moment. This has all been undertaken as part of the NIHR-funded program grant. And I would like to acknowledge other people that have had significant input into the work, including Asad Baksh, who did a lot of the analysis, James Smith, and Rory Sheehan, who helped with clinical interpretation, and of course, Angela and the other PETAL investigators that provided input. So in terms of background, I think we have covered in the earlier presentations already a lot of the background, but just to reiterate that challenging behavior in people with a learning disability is a common issue. It's a frequent reason for referral to specialist services in particular, and associated with harm, social exclusion, involvement of the police and criminal justice system, and understanding the underlying issues and how the clinical, how they affect clinical outcome is important in providing services and developing effective interventions. You know, some of the factors may include mental health problems, which may be associated with aggression due to irritability in, for example, mood disorders, or in people with paranoia due to hypervigilance and perceived threats. And then in other conditions such as ADHD, perhaps impulsiveness could predispose to aggressive behavior. So what we wanted to do was to better understand aggressive challenging behavior in adults with a learning disability referred to mental health services, which is where learning disability teams often sit, and investigate individual risk factors and identify service level factors that may predict outcome, such as emergency department attendance or hospital admission, and look at whether we can identify specific groups of or subgroups of individuals who are at increased risk or do less well despite support with interventions. And so in terms of what we did is we took data from the trust where I work, which is South London and Maudsley National Health Service. And I know we have American colleagues, so this is a large mental health trust that cover a population of around 1 million or more people, 4 to 5 London boroughs. The trust has developed a what they call a clinical record interactive search system, CRIS, which allows researchers to access de-identified, structured, and open text data held in the electronic health record used by all SLAM clinical services. CRIS has been linked with other data sources, such as hospital episode statistics, so that we can see, for example, when people have been admitted to other hospitals, such as acute health hospitals. And it uses structured fields, for example, for patient contacts by clinicians or diagnoses, which are completed by the clinicians. But because of the nature of the health record in psychiatric practice or in mental health, we tend to also enter a lot of information in unstructured text fields. And so they have developed a natural language processing application, which can search the free text and identify when the clinician is concerned, for example, about aggression, or when they mention particular forms of treatment. So we used this clinical record system between for over a 5-year period, and we specifically selected it to be pre-pandemic so that we do not pick up or get confused by pandemic effects, which of course of its own could also be an important area of investigation. And then used the NLP application to extract mentions of aggression, mood instability, agitation, and irritability from free text. We defined adverse outcome for some of the analyses as at least one of the following. So admission to a mental health hospital, mental health act assessment, contact with a psychiatric crisis team, or attendance at an emergency department. And we identified a total of 1,200 patients or more with a learning disability, who between them had a total of 1,500 or so episodes of care. So the analysis is mostly at the level of episodes of care. So in terms of various conditions that we included in our analysis, or what we were able to look at in our analysis, was various diagnoses, including autism and related conditions. In this case, we referred to it in the published work as pervasive developmental disorder, because that's the terminology used in ICD-10. Severe mental illness, which mainly refers to psychotic conditions such as schizophrenia, schizoaffective disorder, and mania. And then common mental disorders, which are depression and anxiety, as well as other conditions, including genetic conditions, epilepsy, and so on. We extracted information on medication. We used physical health medication as a proxy for physical health, so certain types of physical health medication, including prescription of pain medication. And then used, as I mentioned already, NLPs to search free text for mood instability, agitation, irritability, and aggression. And so first of all, just an overview of the demographic factors associated with aggressive challenging behavior. So we were able to calculate the number of mentions in the notes of aggression as an indicator of level of aggression, I suppose, or consistency of aggression, and then divided into low aggression, moderate aggression, and high aggressive episodes or mentions in the episode. And so here you can see the association between those degrees or severity of aggression in episode. So in summary, what we can see, maybe I can put on my laser pointer, is that the degree of intellectual disability is associated with aggression, mentions of aggression, and particular mild learning disability, and to some extent moderate learning disability. Younger people are more likely to present or have as feature of their presentation higher levels of aggression, as do males. So in the high aggression groups, so 60% males. There was some association with ethnicity, but it was not very clear or consistent, I would say, as we shall see in a minute. Then in terms of clinical and service factors, autism was associated with degree of aggression in episodes. So about 60% of individuals who were deemed to have a high level of aggression in episode had a diagnosis of autism. Similarly, but to a lesser extent, ADHD. And then there were also associations with severe mental illness and common mental disorders, personality disorder, physical health. So about 43% of people who had higher levels of aggression during episode had some physical health concern that required prescription of certain medications. And a very high proportion had been prescribed psychotropic medication, and there was a clear relationship between psychotropic medication prescription and the level of aggressive behavior. There was also, interestingly, associations with mentions of mood instability, agitation, and irritability. I think the latter two are not a surprise because we know that are often associated with aggressive behavior. And then, not surprisingly, as expected, well, as known already, if aggression was associated with use of Mental Health Act, mental health hospital admissions, contact with the crisis team, and attendance at A&E in episode. So here you can see it's quite a strong relationship. So people who did not present with aggression, about 1 in 4 during the episode attended A&E, whereas in those with highest level of aggression, about 2/3 attended A&E during episode. And then, of course, there was association with mental health professional contacts, as well as increased likelihood of mention of concerns about social care package or home care package in episode. So then we adjusted all of these factors in an adjusted analysis to see which are the more important factors, and that included age remained an important factor. Of course, the length of episode was also associated. And maybe I should just go back and also mention, so male sex still had some association with aggression. And of the clinical variables, diagnosis of autism remained associated with aggression, as did medication, certain use of medication, and agitation, mood instability, and irritability. So we next looked at which of these factors will be associated with adverse outcomes as defined, as I mentioned earlier, through contacts with A&E, crisis team, and admission under the Mental Health Act. And so what we found was that intellectual disability level is still associated, but in this case, it's people with mild learning disability that were more likely to have a poor outcome, as if you want, if they presented with aggression or had aggression as a significant feature of their presentation. Whereas ethnicity was less clearly associated with an adverse outcome. In terms of clinical factors, interestingly, and I think as Sujit already mentioned, people with autism were less likely to have an adverse outcome as defined in this project. So we're less likely to be admitted, less likely to have the Mental Health Act assessments, less likely to have crisis team input. Whereas having a diagnosis of personality disorder increased the likelihood of such outcomes. And interestingly, also having a diagnosis of depression and anxiety also increased the likelihood of such a poor outcome during the episode, as did mentions of agitation and, to a lesser extent, irritability. In terms of service level factors, and these are fairly crude, total mental health professional contact. So of course, if the person has more difficulty, they would have more contact with professionals. So that was also associated with adverse outcome. Whereas mentions of social care package or home care package had a less clear relationship with adverse outcomes over time. But I think if one were to look at that in more detail, there may still be an association. So what we did then was to look specifically at a way to look at subgroups of patients. And that's because we realized that, of course, group level data may not necessarily identify specific groups of people who may be at increased risk. And so we wanted to characterize potential subgroups in adults with learning disability referred to mental health services, presenting with two distinct conditions. So aggressive behavior and common mental disorders. So we wanted to see if we can pick up differences between these two common presentations in terms of the kind of people that we may need to provide with additional support. So it's the same data set more or less, but in this case, we apply cluster analysis. I'm not going to say much about the analysis itself, the analysis method, in the interest of time. It is quite complex, but nonetheless, the results are quite interesting. And firstly, here is the case of patients with aggression. And so the clusters of patients that we could identify, and these are exemplar patients within each cluster, are given on the screen. I appreciate that it's a very sort of cluttered way of presenting it, but I think worth highlighting the last two clusters, cluster 4 and 5, which are the two clusters associated with adverse clinical outcomes. And typically, these seem to be individuals, male individuals, young male individuals, in one case with mild learning disability, other with moderate level of learning disability, both clusters associated with a diagnosis of autism, having quite a bit of medication prescribed, presenting with agitation, and also requiring quite long episodes. It's also worth noting that in one case, we identified that people from ethnic minority groups may be particularly prone to having a poor outcome if they are young males with autism. Another thing that may be worth mentioning is that in some clusters, such as cluster 1, where you have very long episodes of care, seems to be associated with having mentions of social care package and or home care packages in the notes. So, I mean, at clinical level, this makes a lot of sense. We all know that we often come across situations where there's lots of concern about what's happening at home, about the support that's being provided. And of course, in those cases, it also requires a lot of effort and support to make a change. So in contrast now, in the case of patients who presented with common mental disorders, so depression and anxiety, there was only one cluster that was associated with adverse clinical outcome. And in this, the sort of exemplar patient is quite different. And again, men, but in this case, older men, who may also have physical health concerns and are less likely or have very few mentions of aggression. Whereas individuals with autism, there are a few clusters that included, in this case, individuals with autism. So cluster 6 up here, and let's quickly see cluster 8 down here. So, and neither of these clusters were associated with adverse clinical outcomes. So quite different from the clusters where there were prominent aggression. So there they are. So I would like to emphasize that there are some limitations to this work. So the analysis method did not allow for in-depth look at past experience or developmental history. So like trauma, for example, which I think was mentioned earlier. Also, we were not able to look in a lot of detail at historical intervention. So, for example, people may have received inputs during childhood that may be relevant to later outcome. The mental health electronic case records may not include sufficient detail always on home situation and care packages, as well as activities which are typically managed by our local authority colleagues. And then, of course, there may be much more subtle things like staff training and management and so on, care home management, which we're not able to address fully in these kind of data sets. But nonetheless, I think there's some broad conclusions that can be made from these kind of analysis. And one is that mental health conditions are associated, certain mental health conditions are associated with aggressive challenging behavior, although the association weakened when adjusted for other factors. And similarly, physical health concerns, as is indicated by physical health medications, was also associated with higher frequency of aggressive challenging behavior. But again, that association weakened when adjusted for other factors. An important finding, I think, was that common mental disorders were an important predictor of adverse outcomes, so admission to hospital, including admission to hospital, which suggests a need for optimization of screening and treatment of mood disorders when people present with features of aggression to improve outcomes. Furthermore, mood instability and agitation, irritability were also associated with more mentions of challenging behavior, and in some cases also outcome. And these sort of more broader transdiagnostic symptoms may indicate underlying mechanisms. And I think one could think of using measures of these features in response monitoring, as well as potentially think of it as potential targets for specific intervention. And to me, it was striking that concerns or mentions of home and social care packages was associated with aggression to some extent, and possibly longer episodes of care, suggesting that really there is a need to also think more broadly about what is happening in the person's life and how they are supported if we are going to make a real change in terms of providing people with better outcomes. Autism, it's interesting findings. So neurodevelopmental disorders were more common, and 60% of those in high aggression group had a co-occurring autistic condition. But at the same time, those with a diagnosis of an autistic condition had a decreased likelihood of adverse outcomes. And we think that that may represent the effects of a relatively recent widespread focus on behavioral aspects of care in England, using interventions such as positive behavior support and successful focus on an understanding of environmental triggers and how to manage that. But nonetheless, the cluster analysis highlighted a subgroup of young autistic men who are likely to require considerable input and are prescribed high levels of medication, and who are more likely to experience admission and other adverse outcomes, and who may require additional support and intervention. So in terms of practical implications, I think it is possible to identify individuals with aggressive behavior during their presentation who are likely to end up in hospital or experience crisis presentations. And I've given some of the sort of the factors that we have identified there. I'm particularly interested in the young men with autism and who may be from minority ethnic backgrounds as well. And I think we really need to think how we can better manage difficulties when they arise in those individuals, and target interventions as well. So one suggestion would be to screen and treat for common mental disorders. And of course, like we already do, but never should forget, to address physical health concerns and really consider environmental home situation, particularly in young men who we know may not do as well as to think how we can better address people's cultural needs to improve outcomes.